Kia ora koutou, welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. My name is Dr. Helen Carr, I'm a GP, and today we are joined by Dr. Alwyn D'Souza to talk about the full blood count. Dr. Alwyn D'Souza is a consultant haematologist at Wellington Hospital, where he has worked since 2006. He completed his medical training at Otago Medical School and completed the majority of his postgraduate training in Wellington, as well as spending time at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. His special areas of interest are hematopoietic stem cell transplantation and lymphomas. He also has an interest in medical education and is a former chair of the New Zealand Joint Training Committee in Haematology. Welcome, Alwyn. Thank you very much for being here.
Kia ora, Helen.
So I have to admit, as a GP, I habitually order a full blood count without really thinking why. It just seems like one of these tests that no one's ever going to say, oh, there wasn't an indication for that. But is that kind of liberal approach to ordering full blood counts, wrong? And is there harm in what I'm doing?
No, not really. I guess it depends on the wellness of the patient. If someone's not well, I think a full blood count is a good place to start because it will tell you whether something is wrong in a lot of cases, even if it's just there's an inflammatory process and someone's developed anemia, it tells you that there's something going on. If the patient's completely well, it's hard to know how much extra value you'll get from a blood count.
So how often is an abnormal result due to something like lab error or a transient state like dehydration? And what would be your approach to retesting when we receive an abnormal result?
So the first thing is there are some transient abnormalities we see in blood counts related to an intercurrent illness. And in the hospital setting, probably one of the most common things we see is a high hematocrit or high hemoglobin related to a patient being unwell and dehydrated. So in those sort of circumstances, you'd usually repeat the blood count to confirm, and particularly when the patient's well again, and that will tell you whether it's something that's important that needs further investigation or you can ignore. Likewise, when someone's unwell, there may be a whole lot of reactive changes on a blood count, like a high white cell count, high neutrophil count, high monocyte count, or even a high platelet count, which just reflects the medical problem at the time, usually inflammation or infection. So it depends on the severity of the abnormality and what's happening with the patient at that time as to how much you need to worry about it. In the lab, the way the lab works, a full blood count is put through an analyzer, and if the blood count is completely normal, a human doesn't actually then get involved with looking at that blood count. The background middleware or software in the lab will then just authorize the result and it'll go straight out to the requester. If there's something abnormal, then a human gets involved to look at what the analyzer has flagged, and then they'll decide about whether a blood film needs to be examined to look at that blood count more closely. Now, some abnormalities are only mild, and we won't look at a blood film if the abnormalities are only mild, because many of them will be transient. But if something's more significant, a scientist will look at it. And if it's clinically significant and not easily explainable, they'll normally pass it on to a hematologist to look at. Or if it's explainable but something serious, they'll pass it on for us to have a look at as well. So there are a number of steps along the way that will determine whether an abnormality is significant or not. From the point of laboratory error, labs work to normal ranges. Now, normal ranges have to be created from a normal population. Now, in a normal population, our normal reference ranges most of the time will only incorporate about 95% of the population. So if you happen to be in the 2.5% either high or low in a normal distribution, your results may be outside the normal range. And so if you've got a stable but abnormal result, it may just be that your patient is one of the outliers just outside of our standard deviations. So depends on the abnormalities. Probably the most common false results we get is from the bleeding process. So the blood count or the blood test has been difficult to obtain and therefore is clotted partially when it's put into the test tubes. And that can affect the blood counts, it can affect the coagulation screen. And so particularly with coagulation screens, if they're abnormal, we always ask for it to be repeated because the coagulation screens are so susceptible to, a difficult draw or the specimen being activated and clotting. So in that situation, we always ask for it to be repeated. And in most significant abnormalities, we'll ask for it to be repeated.
That's quite reassuring to hear that there are some people who are just sort of outside the range, because I think that's a lot of the GP strategy is, recheck, test that it wasn't spurious, and then if it is slightly abnormal but actually not changing, you just sort of continue to monitor and don't necessarily trigger a cascade of investigation. So it's good to hear that that's a sensible approach.
Yeah, I think that's a good way to go because there are a lot of abnormalities that are only very mild, and unless you're seeing a trend in them, they don't warrant further investigation, or investigating them is going to be fairly unfruitful. You're not going to find a cause necessarily for it. If there is something that's flagged by the analyzer that's serious, even with minor abnormalities, then a scientist normally looks at it and then it gets passed on to us. So most of the time with serious things, there will be something that will alert us in the lab to alert you.
So I thought we could just start at the top. I think most GPs know the pattern very well off the top of their head of the order of the cells, but I thought we would go in order apart from talking about anemias, which will be outside of the scope of this episode. So hemoglobin, it's not uncommon that we get a call sort of 7 p.m. on a Friday from the lab saying, oh, you've got a patient as a result of a hemoglobin of, say, 75 or something which we weren't quite expecting. Obviously, taking into the clinical picture into account, is there a certain cutoff in your head where you think, well, this patient's considered sort of unstable with a certain hemoglobin, or does it all depend on how quickly it's dropped and the patient's comorbidities?
Yeah, actually, you've hit the nail on the head, actually. So the hemoglobin anemia will be tolerated to varying extents by the condition of the patient. Children can have hemoglobins in the 20s and 30s and not feel very well, but actually be okay until the next day. Fit adults and young adults and even many middle-aged adults will tolerate a hemoglobin of 80 or less and once again not feel very well, but it doesn't necessarily mean it's an emergency. The more comorbidities someone has, the more likely they're not going to tolerate things like anemia and how quickly it's dropped. So someone who's post-op where the hemoglobin has dropped by 20 points but might have only dropped down to 100, they'll probably feel symptomatically anemic, whereas someone who has gradually drifted down to 100 probably won't notice anything at all, actually. So it depends on the circumstances, and we get those calls quite frequently where, once again, there are critical alerts that the lab uses where they have to ring one of us to say, what should we do about this? And we look up the details on the form. So clinical details are really helpful and important because that tells us, quite often that tells us whether it's an expected result or whether it's unexpected. And it gives us a bit more clinical detail around how worried should we be about this result and can it wait till the next day, or do we need to try and ring someone urgently to say, look, you've got this result, you should do something about it. So if someone has, hemoglobin of 80 and they have angina, we'll ring you about that if that's what the clinical details say. If they say, routine well person assessment, we won't necessarily ring you about that result, but we might message you to give us a call the next day, particularly once we've had a look at the blood films to see whether there's any clues as to why the patient is anemic. So it depends on a number of factors. Now, if people are doing things well and by the book, they'll have clinical details on the request form, which will be really helpful for us interpreting that. And also when we talk to you, we already know what you're thinking. If they're not, it makes it much harder and we're more likely to give someone a call because we don't understand what the circumstances around the test are.
That's a good point because I wouldn't have thought of it as sort of a way to prevent yourself getting a call in the afternoon, but that's advantageous as a
It is.
Yeah, it's a win-win situation by the sounds of things.
Yep.
So my understanding as well is that there seems to be a move away from transfusing at sort of 80 or at the higher level and the move is towards correcting the underlying cause. Is that a trend that people are less likely now to do a blood transfusion in general?
Yeah, that is. And I think that's been a gradual process of, working to the premise that first do no harm. And if someone doesn't need a transfusion, then don't give them a transfusion. If they need it, then by all means give it. But even though blood in New Zealand is actually very safe, the risk of viral infections like HIV from a blood transfusion in New Zealand is estimated to be at less than 1 in a million units. For things like hepatitis B, about 1 in 400,000. So it's very safe, but things can go wrong. And I often think about things as, if someone got a bad complication, would I regret having given them a transfusion or manage them in this way? And if the answer is yes, then you probably shouldn't be doing it. If the answer is no, they needed it, then that is the right thing to do. In interpreting whether someone needs a transfusion, you also need to think about why they may be anemic, and is this a transient problem that's going to correct itself, say like a post-operative condition, or is this something where it's not going to be corrected quickly or easily? So, for instance, in the hospital setting, when we're managing patients with acute leukemia, we know that when we give them chemotherapy, their hemoglobin's not going to recover for weeks or months. And so a hemoglobin of 80, we know it's just going to keep on going down. So we would transfuse in that setting. But if someone has, say, iron deficiency, anemia, and they're otherwise well, if you replace the iron, their bone marrow will start to respond to that iron within about a week. And so if they're otherwise well, you've got time to wait and see how they respond to the treatment you're given.
So moving on to the hematocrit, are the hematocrit and the hemoglobin proportionally related in that the higher the hemoglobin, the higher the hematocrit, or is there an element where the hematocrit can go up higher than the hemoglobin, in which case you think of other causes?
Yeah.
Could you talk a bit about the relationship between the two?
That's a great question. I think of them as being proportional. Annoyingly, the reason why we sometimes use hematocrit or hemoglobin is that different conditions are defined in different ways. And so for most things, hemoglobin is actually what we use. The only things I really use hematocrit for is when I'm considering conditions like polycythemia rubra vera, where the hematocrit is part of the diagnostic criteria. And so then it becomes important to know what that is, and the management decisions are based on the hematocrit. But in most other circumstances, hemoglobin's actually easier to understand. Most clinicians understand the severity of either anemia or polycythemia by the hemoglobin rather than by the hematocrit.
In my practice in particular, we have a lot of raised hemoglobin, often sort of untreated, maybe obesity, hyperventilation syndrome, or lung disease. I find that when we do start the cascade of investigations off, it's quite uncommon that we actually find something meaningful.
Yeah.
What would be your approach to investigating a raised hemoglobin or hematocrit, and what are we really trying to figure out and exclude?
Yeah. So for a raised hematocrit, really what you're trying to figure out is, does this person have a primary bone marrow problem, i.e. polycythemia rubra vera, which is a myeloproliferative neoplasm, or is it secondary or relative, in which case it doesn't matter that much. You manage their underlying secondary problem and you don't really worry about the hematocrit at all then, in reality. So once again, annoyingly, the World Health Organization and another group, they've lowered the bar for investigation for polycythemia rubra vera. So now someone who's got a hemoglobin or hematocrit that's persistently above almost the normal range, it's warranted to investigate. Now, if you have a known secondary cause and it's only mildly above the normal range, I wouldn't investigate those people. However, if you've got either an extremely high hemoglobin or hematocrit, or you see someone where their hemoglobin and hematocrit are steadily increasing, you know that there's something else going on. And in those patients, then I'd go on to do further investigations. Now, in New Zealand, we historically have had our district health boards, and the different areas have slightly different clinical pathways that the regions follow. In the Wellington region where we are, we have a set pathway for if you've got a persistently high hemoglobin or hematocrit, you may be able to identify what the secondary cause is, but we also then recommend that they have something called the JAK2 mutation tested, because we know in polycythemia rubra vera, about 95% of patients with that condition will have that mutation. So if you have an elevated hematocrit and it's JAK2 negative, it's not very likely they're going to have a primary bone marrow problem. There's about 5% of patients who will be negative for that. They'll usually have a different mutation in what's called the exon 12 JAK2 part of the gene. And those people can usually be detected by the fact that they'll have a suppressed erythropoietin level. So in our pathway, we have, if you've got a high hematocrit that's persisting, so you know it's not from dehydration, then you do a JAK2 test and you do a serum erythropoietin, and then you look at the combination. So if JAK2 is positive, they've got a myeloproliferative disorder of some description, whether it's polycythemia or one of the others. If it's negative, you then look at the erythropoietin level, and if that's normal or high, then you know that they don't have a primary polycythemia. And those are the ones that we do the exon 12 testing on. Now, different labs have slightly different criteria, but they'll usually give you some guidance. We have a health pathway for that, which means technically you don't need hematologist approval because it's a pre-approved pathway. And so if you state as per health pathway, those tests get done if the blood count is consistent with the health pathway.
In the Wellington region.
In the Wellington region, yeah. And the other regions will have something similar, but they may not be exactly the same.
So the red blood cell is one of these lines that I almost never look at. It was only through thinking about it more closely that I even realised it was there. How's the red blood cell different to the hemoglobin?
It is slightly different, but from a clinical point of view, the only time I ever look at a red cell count is when I'm thinking about, does this patient have a thalassemia? Because in thalassemias, they may be anemic or microcytic or both, but the red cell count is usually high. So that's the only time I look at that, actually. So it's helpful from that perspective, not really from any other perspective, actually.
And just to say that, we're passing over the mean cell hemoglobin and the the mean cell volume. So that brings us to platelets. I guess for you, what platelet-related changes would you like to be consulted about as a hematologist? Is there anything particularly important that we need to know?
It's actually trends over time. So once again, the diagnostic criteria for essential thrombocythemia, which is mainly what we're concerned about, there are some other blood malignancies, including some of the myelodysplastic syndromes that are associated with high platelets as well. But mostly we're concerned about essential thrombocythemia. And so if someone's got a high platelet count, but they've got a pneumonia, don't worry about it. Just retest when the patient is well, and it should normalize. If you test too soon, it'll stay elevated, but usually, 2 or 3 weeks after the inflammatory process has settled, the platelet count should have normalized or be close to normal by that time. And sometimes we see this in the hospital in people who have got a post-op infection. They can push their platelets up to very high levels, 12, 1300. But what I do in that situation is look at when was their last blood count done before surgery, and if it was normal, then I think it's probably going to be reactive. Likewise, if you get a high platelet count, if you look at the trend in that patient, you might see, okay, well, this is a one-off, or you might see, actually, it's been a little bit high for a little while. And so it depends on those trends as to what to do. Now, if they're moderate to extremely high, so say over 700 or 1,000, you're going to take a lot more note of a count that's at that level and retest sooner and then do further investigations if they stay elevated. We do see, eventually we get referred some patients who their platelet count may only be 450, 500, but it's persisted like that for some years. And the things that I look for is, do they have usually a chronic inflammatory condition, sometimes infections, that are driving that up? And some patients will. They have things like rheumatoid arthritis or, SLE or inflammatory bowel disease. And it's pretty clear they've got a secondary thrombocytosis. But other people will be completely well. And I think if someone is completely well with a high platelet count that's persisting, then particularly when it's been going on for a long time, they're very likely to have a myeloproliferative disorder then. And those are the ones that require further investigation. So either very high, that's not coming down quickly, or someone may only have a low level elevation, but hasn't come down in the absence of inflammatory or infectious problems. with iron deficiency being in there as well, because high platelet count is associated with iron deficiency anemia as well.
Great. So moving on to the white cell count, does the difference between whether there's neutrophils that are raised or lymphocytes that are raised tell you clinically relevant information?
Yeah. So this is quite a common referral we get with neutrophils predominantly. And I guess we don't get many patients with a high neutrophil count referred, because most of the time there's a easy explanation and people are pretty comfortable with that. The patients we get referred mainly are the patients who have a slightly low neutrophil count, which is actually pretty common in the community. We see a lot of these where they're just mildly reduced, but it's in isolation. There aren't any other abnormalities on the blood count. So when I see a low or a high count in a particular cell line, I always look at all of the cell lines. So I look at the hemoglobin, I look at the MCV, I look at the hematocrit, and then I look at the platelets and the white cells. If you have multiple cell lines which are abnormal, it raises your interest a lot more, particularly if they're low. So the more cytopenias you have, the more you're likely to think this is going to be significant. We do commonly see mild neutropenias where the hemoglobin's normal, the MCV's normal, the platelets are normal. And if they're only very mild, between 1 and 2, we don't worry too much about those. Functionally, that patient will probably have normal neutrophil function. We know that the body's got quite a lot of physiological reserve. So a neutrophil count between 1 and 2, even though it's low, actually you can live quite happily with that without any real risk of overwhelming infection. As it drops under 1, the risk gradually goes up, and it's like an exponential curve. So, yeah, the risk is mild, or there's a mildly increased risk of infection when the neutrophils are between 0.5 and 1, and then it starts to escalate quite steeply below 0.5, and then particularly below 0.2, which is what we call that profound neutropenia. The risk of infection also, though, correlates with the underlying cause. So if you have, say, an immune neutropenia, quite often the neutrophil precursors in the bone marrow will be normal, but the mature cells just getting knocked off by an immune process, either antibodies or some sort of lymphocyte response. In those patients, they often respond very normally to infections, and you don't see an increase in infections. If patients have bone marrow failure syndromes, though, they are much more likely to be symptomatic from their neutropenia. So you'll see either prolonged infections where patients take a long time to get over them, or severe infections, mainly bacterial infections for neutrophils. With lymphocytes, in general, it's fairly unsatisfactory investigating for lymphopenias. We don't commonly find a cause for low lymphocytes unless it's very low. And the one thing I always think about is HIV, checking for HIV. But we see low lymphocytes as a very non-specific thing. I think a lot of immune problems can be associated with a mildly low lymphocyte count. So most of the time, it doesn't mean anything. The thing that I would check would be HIV. For high lymphocyte counts, it depends on the severity. So mildly elevated lymphocyte counts occur with many inflammatory and infectious problems. And as you've alluded to as well, sometimes you get common things like smoking that can elevate the lymphocyte count slightly or the neutrophil count slightly. And if you've got a mildly abnormal result that's persisting but they smoke, I wouldn't worry too much about that unless you've got a trend upwards. If there are other worrying things in the blood count, often those will get flagged. Many myeloproliferative disorders will be associated with a high basophil count. So whenever I see a high basophil count that's persisting, almost always have got a myeloproliferative disorder until proven otherwise, really. So what levels of lymphocyte counts do we worry about? Once again, it depends. We know that the most common type of chronic leukemia is CLL, chronic lymphocytic leukemia. To make a diagnosis of chronic lymphocytic leukemia, even at the earliest stage, where they may not need treatment for more than a decade, you have to have a clonal B-cell population of over 5 that has the right phenotype. Now, knowing that the clonal population has to be 5, you usually need a lymphocyte count at least over 8 for the clone size to be more than 5. So in our lab, we stopped doing flow cytometry on mild lymphocytoses because If we diagnose what's called a monoclonal B-cell lymphocytosis, who cares? Because they're probably not going to turn into anything. And even diagnosing CLL with a lymphocyte count of 8, unless they've got cytopenias associated with that, that person's probably not going to come to our attention, maybe ever, or maybe not for another decade. And so I wouldn't be too worried about those things. When there's a high lymphocyte count, they do get referred. The scientists will have a look at it, and often we'll have a look at it. If it looks like a typical CLL type morphology, we might say, could be that, retest again in 3 months' time. If there's something that's not CLL, then we investigate further. So there are other blood cancers that can present with a lymphocytosis. Most of them aren't very common. There's stuff that we see, but you guys probably won't, mantle cell lymphoma, things like hairy cell leukemia. But usually we'll have flagged, we don't like the look of these cells. We think there should be further investigations done. It will normally then recommend flow cytometry on the blood as the next investigation. And if we're very convinced that it's likely to be abnormal, we'll normally say, refer to us to be seen as well. If it's a chronic lymphoproliferative disorder, we'll normally say refer as or non-urgent referral, because they don't necessarily need to be seen urgently. They may be, we'll see them in a month or two's time.
Blood cancer is a whole nother topic, but with lymphoma, it's lymphocytes and lymphoma, you kind of expect that the lymphocytes will be up, but could you talk through some of this changes, clues on a blood film that might lead us towards if we're suspecting lymphoma?
Yeah. So it's not very common that you see lymphoma cells in the blood. There are some indolent lymphomas that you will. Mantle cell lymphoma commonly affects the blood. Follicular lymphoma can affect, you can have cells in the blood, but it's not very common. I think only up to a quarter at most would have it in the blood. And things like marginal zone lymphoma, which are not very common lymphomas. We see quite a bit of them, but they're not very common in general practice. So in most cases, it's pretty unusual to see lymphoma cells in the blood. So most of the time, lymphomas are diagnosed because people have persisting lymphadenopathy that's clinically apparent, or they've got these symptoms with night sweats and significant weight loss over a short period of time. And those are the things that have alerted the clinician there's something going on. It's not very common we'll see them in the blood.
So eosinophils, we think of them obviously with atopy and asthma. But is there any other big category or things that it's important not to miss, and what prompts you to want to investigate further?
Yeah, so by far and a long way, the most common cause of eosinophilia is atopy, in New Zealand anyway. And so those mild eosinophilias, if the clinical context is right, then I'd attribute it to that. Parasites are much less common in New Zealand, but we do see a small but significant proportion of people who've been to the islands who they'll have picked up a parasite, and that's why they've got a high eosinophil count. Not that common, but enough to think about, really. And so things like travel history become important in that situation. A history of atopy, particularly if they're symptomatic at the time, either eczema or hay fever or asthma, then you've got a ready explanation for that. We don't worry about that too much. Eosinophilia is pretty unsatisfying to investigate as well. We see a little bit of this, and even we're not really sure at what point we should be investigating. If someone has a very elevated eosinophil count, 10, 20, we'll always see those patients. There's a very annoying group of patients that will have, not the patients are annoying, but their results are annoying, where the eosinophils might be slightly elevated, and there's not really a good explanation for that. Now, most of the blood disorders that are associated with a high eosinophil count are already rare. So we look at a blood film to look for leukemias, look for any evidence of lymphomas that can cause a high eosinophil count. The minor proliferative disorders can be associated with high eosinophils as well. But if there's nothing obvious on the film, most of the other causes are extremely rare. So I'd probably just follow it, and if it's going up over time, 1, 2, 5, 10, then go, actually, this needs to be referred. If we're seeing that pattern in the lab, we'll end up saying refer. But when they're only very mildly elevated, unless the patient's unwell, it's usually fairly unfruitful to investigate.
I actually realised I skipped past monocytes. Easy to do.
Yep.
when are they significant, and is it something that generally the hematologist will let us know if we need to?
Yeah, generally we will. So monocytes go up fairly commonly with reactive processes and infections. So in the setting of an inflammatory problem, wouldn't worry too much about it. And I think about monocytes differently, and this is the same with lymphocytes as well, in older people compared to younger people. Going back to lymphocytes, if you have a lymphocytosis in a young person, it's probably going to be a viral infection. If you see a significant lymphocytosis in an older person, you start to think about lymphoproliferative disorders, chronic leukemia is much more likely, particularly if it's persisting. So the age of the patient makes quite a big difference. That applies to monocytes as well. In patients who are young, most causes of monocytes are usually inflammatory or infective causes. In the older population, we start to think about conditions like chronic myelomonocytic leukemia, which is a form of bone marrow failure syndrome, very similar to myelodysplasia. So in those patients where they've got a persisting monocytosis, they're more likely to have an early CMML. If they've got anemia associated with it, then that raises the spectrum much more likely. So we do see quite a few people who've just got a monocytosis, and if it's mild, we just follow that and just recommend that they get regular blood tests, which might be every 3 months or 6 months or annually, if it's only very mild. And if the trend is upwards, we might investigate. Most commonly, though, we'll only recommend investigations if we see something worrying on the blood film, or it's associated with significant cytopenias where it becomes important then to make a diagnosis because there might be a treatment involved with that diagnosis. Or in patients who are developing cytopenias, it then has prognostic significance as well. So it's important then to make the diagnosis for the patient.
Cool. So 2 more cell groups. There's the basophils, which
Yep.
you mentioned, if they're raised, are usually associated with some kind of myeloproliferative disorder.
Yep.
Is that?
Yep.
What other things can raise them, and is that something that if there's a problem, heme will say?
Yeah, look, that's correct. So I guess I think of basophils like Fight Club. What's the first rule about Fight Club? Don't mention Fight Club. What's the second rule of Fight Club? Don't mention Fight Club. What's the third rule? Don't mention Fight Club. So it's a bit the same with basophils. Myeloproliferative disorders 1, 2, and 3 until excluded. It's very rare to get elevated basophils, particularly persistently elevated basophils for any other condition. There are some other conditions, but extremely rare for it to occur persistently. Inflammatory bowel disease can cause a high basophil count. I think that's just about the only other thing I can remember. So it's very, very rare. Most of the time when people have a high basophil count, they will have other abnormalities. If someone has a persistingly high basophil count with no other abnormalities, we still think of chronic myeloid leukemia, or CML, not CMML, as a possibility. And we've picked up a few because that's the very earliest thing that occurs in CML, a persisting basophil count. And then the white cell count goes up or the platelet count goes up. So yeah, really myeloproliferative disorders, including CML, as 1, 2, and 3. Yeah.
There's a group that I hadn't even registered in my head that I just saw recently, that NRBCs, the nucleated red blood cells. Can you tell us a bit about those?
Yeah. So in your bone marrow, when red cells are developing, they have a nucleus. And in young red cells called proerythroblasts, they'll have a very large nucleus and occupying most of the cell. As the new red cell matures, the nucleus gets smaller and denser. And then just before they go out into the peripheral blood, the nucleus is extruded from the cell. So mature red cells don't have a nucleus. When they first come out into the cell, they'll have a lot more RNA than more mature red cells. And we can pick that up when we stain the cells when we're making a slide, because they have a purplish tinge to them. So those cells we call reticulocytes, and they look a bit different. So we call them polychromatic red cells, which means they're not just pink, and they look different. And if you did further testing on them, you'd be able to work out that they're reticulocytes. Now, if you have nucleated red blood cells in the peripheral blood, it is always abnormal. But sometimes there's a good explanation for why they're there, and it's going to be a transient problem. If someone is extremely unwell, either with severe hypoxia or a severe sepsis, they'll push out nucleated red cells into the blood, usually in association with immature granulocytes like metamyelocytes and myelocytes and so on. So we see a lot of this in the hospital, and if they're in ICU or they're clear they're already unwell, we don't worry too much about it. We just say repeat when the patient's well. In primary practice, it's probably more worrying than in the hospital because the assumption is that the patient's well, and if they've got nucleated red cells in their blood, then something's going on with that patient generally, unless you're about to send them to hospital because they're very unwell. So the things that we think about are conditions where there's a high red cell turnover. So if someone's had a brisk acute bleed, they will push out reticulocytes into their blood and they'll push out nucleated red cells. Now, you'll know about that because the patient will be unwell if they've got those in the blood. If someone is very hypoxic, you'll know about that. If someone has a hemolytic anemia, then they'll push out these early cells into the blood as well. Once again, the patient will probably be anemic and they're probably going to be seeing you because they're just not feeling right. And you'll do a blood test and they'll be anemic, they'll have nucleated red cells, and we'll look at a blood film and say, we think there's ferrocytes in the blood, or there is something else that tells us this patient may be hemolyzing, and ask you to do follow-on tests. In patients who have both nucleated red cells and immature granulocytes in their blood, then we call that a leukoerythroblastic film. Now, once again, if they're acutely unwell, that's okay, we can explain that. If they're not acutely medically unwell, that's a worrying sign because that could mean bone marrow infiltration from something, either benign or malignant, or a bone marrow malignancy of some sort. So the blood counts that I worry about most is when the patient's actually just had a routine test and they've got nucleated red cells in their blood because something's going on for that patient.
Thank you so much for that, Alwyn. That had some really useful points for us and for probably the most common tests that we analyse as GPs. What would be your key take-home messages for our listeners?
So look at the blood count in its entirety because most conditions, there'll be patterns of abnormalities, and either the pattern of abnormality tells you a story or the severity of the abnormality tells you a story. If abnormalities are mild and we haven't made any comments about the abnormalities, it's probably quite reasonable just to follow that abnormality and see what trends develop, because the trends become quite important to tell you about, is something important going on here that needs to be investigated.
Awesome. Thank you so much. If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcast is eligible, so please log them. You'll find links to any relevant resources we have discussed in this episode on our website at goodfellowunit.org. If you'd like to get in touch, as always, you can email podcast@goodfellowunit.org. Thank you for listening.